all the viewers of the Vertebral Views. I'm Dr. Raj Sakhrekar, and we are live and fortunate to have Professor Sean Molloy on our show. I'm currently in Rio Spine Global Congress, and Professor Molloy is in UK, and we say hello to all our viewers. For there might be very few spine surgeons in the world who won't be knowing Professor Molloy because of his experience, and he has kind of trained so many spine surgeons. He is world known with his research. But just to give you a short note, he works as, for those who don't know him, he works as a senior spine orthopedic surgeon at Royal National Orthopaedic Hospital in Stanmore, UK. And he has held the post of clinical lead and also clinical director of the spinal unit in the same hospital. Professor Molloy is an innovator and leader. He introduced spinal navigation surgery to the United Kingdom and has been instrumental in teaching the next generation of spine surgeons to utilize this technique. He has recently introduced spinal robotics to the hospital and did the first robotic-assisted surgery in the NHS. Royal National Orthopaedic Hospital has been chosen as the lead European training site in robotic spinal surgery as a result of Mr. Molloy's lead in training UK and European surgeons in the field. Professor Molloy has patented instruments used in complex spinal surgery and an orthopedic engineering degree. And he has the engineering degree. He has also designed new surgical approaches in the spine, which helps all the spine surgeons across the globe to expand their patient needs and patient care. There are many accolades and laurels he has achieved. Just to summarize, and his memberships, he's a member in the British Association of Spine Surgeons, British Scoliosis Society, Scoliosis Society, and your spine. Professor Molloy, it's all you now, and we are very excited and thrilled to hear from you, and thankful that you accept our invite.
Raj, thank you very much. I'll share my screen now. Hopefully that'll work. Yeah. Okay. Raj, hopefully you see that okay? Yeah?
Yeah.
Look, it's a great pleasure to be asked to give a talk on OrthoTV. Thank you very much, Raj. This is an area really, really close to my heart, really, because when I started first in my orthopedic career, and particularly in my consultant job at the Royal National Orthopaedic Hospital, adult deformity really wasn't actually a speciality in its own right. That was back in 2003, 2004. And whenever I presented cases that had come to me, my consultant colleagues who were very senior to me would say things like, well, the SVA looks okay, the sacral slope doesn't look too bad. But then actually I went on some trips to Burke Plage, where Daniel Chopin was a fantastic surgeon there. And also he taught me a little bit about the work of Dovel Bipere and also of Debussy. And I went on then to meet Pierre Roussely, who's a very formative and great researcher and somebody who actually taught me a huge amount at the time as well. When I came back from France, I started looking at these patients a little bit differently. And you see that on the left-hand side here, here's a lady who I actually ended up operating on, and I'll show you later on. But you can see her in her compensated position where she bends her knees. And of course, you get an X-ray that looks as if actually the sacral slope is not too bad, and actually that the SVA is also not too bad. So that would have been my peers, my senior surgeons at the time, Stanmore, would have said to me, well, this patient doesn't look too bad, Sean, I don't think they need an operation. Of course, I was a young consultant, but when you actually take the X-ray on the right-hand side in the compensated position, in the decompensated position, you see that the SVA is actually an awful lot further forward than what it was on the left-hand side. So the true disability is actually really huge in comparison to what we were actually looking at. Steve Glassman, who became a good friend in 2005 and 2007, published some great papers really showing us that actually in the unoperated patient and also in the operated patient, if you had a positive SVA or a sagittal imbalance, then actually you had increasing pain and also decreased function. but particularly if that kyphosis, so loss of lordosis, was actually lower down in the lumbar spine, these patients did very, very badly indeed. And that's quite simple, really. If you're looking at somebody who has an angular deformity and it's 20 degrees like this, well, it's not too bad. But actually, if it's lower down in the spine, then 20 degrees becomes an awful lot more. So with that in mind and reading about the types of curves that actually people are born with and what we have to try to recreate, I read a lot of the Pierre Rousselet work and went to see Pierre. And of course, Pierre published his initial paper in 2005 and then actually supplemented it in 2017. And I would commend everybody to have a look at those papers and read them in detail. Pierre, over a period of time, started to talk about two different curves, the upper and the lumbar curves. And actually, I think that's very pertinent when we come to looking at segmental lordosis and the future actually of spinal surgery and what we try to achieve with segmental realignment. If we look at this first off, so when I came back from Daniel Chopin and Pierre Rousselet, my teaching was really that we should do PSOs. So I decided I would embark upon that. And of course, around the world, 20 years ago, we all started to do L3 PSOs. And if you look at this patient themselves, actually, there's no interbody support apart from at L5S1, but no interbody support around the actual osteotomy itself, and quite a long working length of the rods, which then actually were more prone to break as well over time. But in addition, we were getting lordosis in an area of the spine that we now know is actually incorrect. And we were over-lordosing the spine in an area and creating a stimulus really for proximal junctional kyphosis. In Stanmore, I had actually been thought, and this is the top pictures there actually of a young colleague of mine who's very talented, Ruz Shafafi at Stanmore, and he did this a couple of weeks ago and sent them to me, and I thought I'll put them on here and just show you that actually doing a Lenke 5 anterior curve can be very, very beautiful if you do it anteriorly. And Ruz is a very young, talented surgeon, and he's done a great correction here. But we've been doing that for many, many years at Stanmore. And the Lenke 5s, we often treat anteriorly, in fact. Because I had had that training of doing the Lenke 5s anteriorly, I decided I would actually start to put the cages that we had at the time, which were ray cages. So, I mean, a bit like the back cages as well. We weren't as blessed as having the cages that we have today. And I started putting those cages in from L2 to L5. Of course, I stuck with doing PLIFs and TLIFs at the level of L5S1, but actually over a period of time, I realized that actually these TLIFs and PLIFs weren't really working for me. And even if actually I got what I thought was a good correction initially afterwards, you can see that these cages, modern day cages, I think I've seen them back out, these expandable cages, but also other cages, they flip, they subside, and they don't actually give us a very, very good spread of the loads. The stress equals force over area. The force becomes quite great at stress points really, and actually you get a lot of subsidence. We recognize this subsidence a little bit more once we actually had SPECT CT scanning, and we were lucky in probably about 15 years ago that we actually started looking seriously at SPECT CT scans and trying to adapt it into our practice, and actually published this paper in 2019. And it was only really then that actually I thought we were overcalling the fusion at the level of L5S1 often with TLIFs and PLIFs, particularly at the end of long constructs. So with that in mind, and also the fact that actually if I was putting these ray cages in and I was doing quite an extensile approach, then we were, I think, stretching and damaging the nerves that pass in between the internal oblique and the transversus in those procedures. Now, the Lenke 5s that we were doing in children, they didn't get this weakness, but we were getting pseudo hernias in patients, and they were really, really not a very nice thing to give a patient and quite debilitating. So there was a lot to learn, really. What was I trying to get around by doing something different? Well, I didn't want to get angular corrections that the PSOs were giving me. I didn't want to be getting the proximal junctional kyphosis above those angular corrections. I was seeing non-unions at the osteotomy site. I was seeing rod breakage at the osteotomy site. I was seeing non-unions through my TLIFs and my PLIFs at 5-1. The pseudo hernias were something I really, really wanted to actually avoid. And also when the SCOLI Risk 1 paper came out, we realized that actually when you were doing 3-column osteotomies, particularly in the very, very stiff spines, that actually the neurological risk was really, really quite significant. So going back to just looking at the literature itself, we were doing a lot of anterolateral approaches for these Lenki 5s, but actually France, Germany, UK was doing a lot of anterolateral work actually throughout the last number of years, even prior to me coming to Stanmore. And you can see that in 1997, Michael Meyer had actually written up doing these patients in a lateral decubitus position, and then of course doing an ALIF at the level of L5S1, but that was of course through a separate incision. And I wondered whether in fact these things could actually be adapted and augmented together into one surgical approach. So Pierre Roussely had written up, and Pierre had discussed this with me on a number of occasions. He used to do the posterior approach first off, and if actually any of the disc spaces opened up at the front, he would fill those in. And he wrote up his series of what we now term to be OLIF or anterior to psoas. But actually at the time it wasn't called an OLIF or anterior to psoas, it was just called an anterolateral retroperitoneal approach to the spine, subdiaphragmatic really at the time. And then we were the first people who published in the world on the prospective series, and I was very lucky to be joined at Stanmore by a fantastic vascular surgeon, Obi Agu, and I'd like to thank Obi for all his massive support over the years, really. We worked together for the last 15 years. We presented 64 cases of extensile approaches to the lumbar spine from L1 all the way down to S1. But very importantly, we were actually describing an ALIF at the level of L5S1, despite the fact that this was through a lateral approach. So that's very important. This was not an OLIF at 5.1, it was an ALIF at L5S1, but through a lateral approach, not a separate Fanon steel approach. And then, of course, Hines, who's a brilliant surgeon from Florida, he then published his OLIF at L5S1, and then that became synonymous really with one of the companies also. And of course, now we have companies also who are doing the what's it called, XL5S1, or it was linked with invasive. But of course, that's just trying to do a patient, keeping them on their side and being able to do anterior to psoas or trans psoas at the upper lumbar levels, and then actually trying to do L5S1. Difficult to do, actually. So how did we do it? Well, our approach we call the MOLIF approach, after myself and Obi, the vascular surgeon. And what we were doing is, if you look at D and E, in D, it's the standard anterolateral approach that people use. We actually put patients lying about 30 degrees in the paper that I'll reference later on. We put them 30 degrees into a semi-decubitus position so that actually we can gain access to the lateral aspect of the spine and do an anterior to psoas, but also then to sneak around into the corridor that actually enables us to be able to do an ALIF through L5S1. And that effectively gives us the same view as if you were doing a supine ALIF on a patient, and we can put a 4-hole plate onto these patients. So we're not compromising ourselves at all. And in fact, sometimes if there are a lot of adhesions anteriorly, it's a much easier approach to do. If the patient's a lot bigger, of course, all of the fat and the contents of the abdomen are pushed away from you, and it makes it easier as well. So just to give you an idea and just to look at a couple of cases really. So this is a case I presented at the EGAS meeting, which unfortunately has stopped, but it was a fantastic meeting in the past. And this was in France in 2013. This is a 61-year-old lady who really has fatigue failure, inability to be able to stand upright really. She's got no radicular pain. She's not actually really a claudicant. She's actually just got decreased walking distance because she's fatiguing and can't keep herself upright. This was her image, quite striking really, but despite the degree of stenosis that she has, which is not critical, she didn't have any claudicant symptoms and she didn't have any radicular symptoms. She actually probably wasn't able to keep herself upright for long enough to be able to get those. So the question is then, what do you do for a patient like this? Well, the mismatch, according to what we normally describe, her pill mismatch, so her pelvic incidence to lumbar lordosis mismatch is 48 degrees, but in reality, is it really that? It's not, because when you check her lordosis when she's lying down on her CT scan, you can see she's got 21 degrees. So her mismatch is probably about 38 degrees. However, 38 degrees for everybody really in the literature at the time, and also definitely back in 2013, everybody immediately thought over 30 degrees of mismatch, you need to do a PSO. And I asked the assembled French surgeons, what would they all do? And everybody in the room said that they would do a PSO. There were 2 or 3 people, very, very senior people, who said to do 2 smaller PSOs because they felt that would actually give a slightly more harmonious spine. But if you look at it, what options do you have? Well, you could do a multiple level TLIF on this patient. And we go back and have a look at those images, and we'll see those in a second. One of the levels is particularly incongruous and actually would be very difficult to do a TLIF or a PLIF on, and to be able to open up. Very, very tough day as well, doing TLIFs and PLIFs at 4 levels of the spine potentially. Would you do a combined anterior and posterior fusion? Well, it's very difficult to do a direct ALIF up to the level of, L2, L3. It's a big dissection. Or would you do a combination of anterior to psoas and then maybe actually do a direct ALIF at 5-1? Well, that's a separate approach. Or would you actually do the standard subtraction osteotomy? So if you look back in it again, you can see actually that the second last mobile level of the spine would be particularly difficult to get a good TLIF into. The end plates are actually quite irregular. There is quite a bit of sclerosis there, and you probably wouldn't get subsidence, but it would be a difficult spine to get harmonious at the end of the day. And the question then is also, if you're not going to get the segmental correction that you need in the lower lumbar spine, what level would you stop at? Would you go up to L2, which actually pretty much everybody in that meeting at the time was saying PSO at the level of L3. That was, of course, back in 2013, so quite a long time ago. We hadn't quite got on to PSOs of L4 at the time, and then they would actually go up to T2. A couple of people did say they would go to T10. Nobody said they would stop at L2. So I knew that we were doing something a little bit different, and it was Behrouz Akbarnia who came to Stanmore looking for ideas where we could be collaborative with our research. And Behrouz was actually very surprised at the time that we were doing quite a lot of these anterior column reconstructions. Pierre Rusili and Daniel Chopin thought me that if patients had a good active extension, when you examine them, that actually often you could stop a bit shorter if you could actually correct the lumbar lordosis. So if you look at this patient, so we did it all through that anterolateral approach, so the MOLIF approach. And you can see that actually I've put 4 cages in here. These are the old tantalum cages. They were what we had at the time. They were the next thing after the ray cages. They were fantastic in terms of their metallurgy, really. But you can see, I mean, this lady had a PI of 59, and now she already has a lordosis of 46 degrees. So she's had a 25-degree correction of her lordosis just by doing the anterior first stage. And you can see on the left-hand side at the bottom, the image, you can see how much you can open up those disc spaces if actually you go through the anterolateral space and you release the ALL. You don't have to take the whole of the ALL, but release it enough, fractional releasing. And for the orthopedic surgeons listening, it's really just like doing a balancing procedure for a knee replacement. So if you look at her then afterwards, what she had, well, 380 mils blood loss, no cutting of any muscles at all, because I do a midline approach at the back and a bilateral Wilsey approach, so going in between the internervous planes. She's had a length of stay in hospital of about 8 days. She's got a very harmonious spine that actually now is balanced both globally and segmentally. And actually she's had her pelvic incidence corrected, or at least her pill mismatch corrected completely. But she's gone home with no real risk of neurological damage because we've worked in front of and behind her chorda equina. And her outcomes are far better than any outcomes that you're going to see with low back fusion surgery, because of course these people are very disabled beforehand, so very grateful that you've actually done a huge job for them, albeit that actually it's really quite standard operating, and it's changing these big deformity cases into kind of low back fusion surgery. So here's the paper that I'd love you all to go and read. We had the great pleasure to be able to go to the World Summit tour and show this actually on a cadaveric model recently. So that's actually online. It's the Remesis company who kindly did that, and actually that's a great thing to be able to watch. Obiago and I were given the chance to do that, and Christophe Albers was great at actually fielding the questions for us and helping us out with the presentation. And really it's an extensile approach from L1 to S1, which enables you to be able to access all levels of the spine that you need through fascial incisions. So if I just show you the fascial incisions, so you can see W1 up at the top there, which is the first window. Now at the moment, we do everything from L1 to L5 through one fascial window. But I think the most important thing about that is that as orthopedic surgeons, particularly, we've always been taught, get to the bone, stay on bone. So actually what you do is you operate, you make a decent size incision, and then you actually have a tiny window by the time you get to the bone. And actually we would implore you to do something different to that. You have to undermine all the tissues, so the subcutaneous tissues, the external oblique, the internal oblique, and then of course the transversus is relatively straightforward. But once you do that, you've got like an inverted funnel where you can actually move the soft tissues up and down, just like you might do an extensile approach in the cervical spine for multi-level ACDF fusion surgery. So you can see that you take the external oblique down and the aponeurosis, so down towards the rectus muscle, and then the internal oblique is left in between. You make a muscle split in that, and then a muscle split in the transversus. Window 2 is the second one, which takes you down to L5S1. You can see we just take a little bit of the anterior part of the rectus sheath, leaving the rectus muscle underneath, and then of course we can retract the rectus muscle and get into the retroperitoneal space because there's no effective posterior rectus sheath. And that enables us then to get down to the L5S1 disc space. We can retract the artery and the vein. Remember that when these patients are in the semi-decubitus position, particularly actually if they're in the direct lateral position, like one of the companies is purporting to do now, that vein, that left-hand vein will really hang down over the disc space, and you need to really retract it up so that you can get into the middle part of that L5S1 disc. In ours, the vein doesn't come down so much, but yes, you do have to retract it up also. And I think navigation will be good for some people to be able to utilize in this type of position as well. We haven't used navigation for this procedure itself. We've become pretty au fait with it, but I think it'd be useful for people when they're going to start. So the paper as well that we wrote up was 64 patients, prospective series of patients. So we've been doing it for about 8 years prior to that, but then collected the 64 up to when we published it. Our mean blood loss was tiny in the MOLIF part of the operation, so less than 100 mils. And you can see our back pain scores improved, the VAS score improved considerably, as did the ODI. So these patients did incredibly well with multiple level MOLIF surgery. And if you look at it also, we didn't actually have any neurological injuries or visceral injuries. I don't really understand the amount of neurological injuries that people purport to have with anterior to psoas. I think you need to be very respectful of the psoas itself. I don't retract the psoas during that procedure. It's why I've never enjoyed or wanted to go trans psoas as well. So I think don't retract the psoas, hold it with a cob, and then do your discectomy whilst holding a cob elevator in your left hand. Do the discectomy with your right hand if you're that handed, and the other way around, obviously, otherwise. We did need to do a revision at L5S1 in that paper for a sacral fracture. I've seen a number of sacral fractures over the years, actually. Probably I do a lot of this type of surgery, and I've probably seen 3 in the last 2 years, and they're sizable injuries. So I think you've got to be very careful with people bending over after doing long construct fixations. I've stopped having non-unions at L5S1, but you're only as good as your next weakest link. I've stopped having proximal junctional kyphosis because of the segmental rebalancing of the spine. So my biggest failure now, I think, is a sacral fracture. So you take this patient who we showed at the very, very beginning on the first slide. You can see that she was in a compensated position and a decompensated position here. She had an old Harrington rod correction. She was a 52-year-old anesthetist, and actually you can see here that actually her images are pretty awful, but often the people with the worst type of deformity give you terrible images. So you have to rely really on your supplementary imaging. And then here you go, here's a CT scan. So for those who are not so au fait with old fusions, you can see the little black area in between the L4 and L5 spinous process is actually the end. It's a metallic marker at the end of a spinal fusion itself. And so I knew from my work at Stanmore that actually the L4, L5, despite the fact that it looks fused posteriorly, there may be potential to actually utilize the L4, L5 area. And of course, there's a vacuum phenomenon in L5S1. If we look at this patient, though, they have a pelvic incidence of 56 degrees, and they only have a lumbar lordosis of 11 degrees. So we need a lot. We need 45 degrees through effectively one segment. So again, when I've presented this case over the years at meetings, everybody has said do a PSO, and that's why I've kind of presented these cases today, really. But what would you do? If you did TLIFs at L5S1, you wouldn't get very much. Yes, if you did an ALIF, you could overcorrect L5S1, but you can't get 40 plus degrees. So you've got to do something a little bit different. Yes, you could, of course, do a subtraction osteotomy, and that's a very, very valid thing to have done in this case. But she did move at L4, L5. There was a little bit of increased uptake on the SPECT CT scan, and that's become a very, very important modality for me in terms of my decision making for surgery and how I revise these patients. I did a Smith-Peterson osteotomy through L4, L5, and you can see there that I've kind of done something that's akin to what you might do for a PSO. I don't do it as much as that these days. You don't need to do it as much as that because when you do an anterior column reconstruction, you also elongate the anterior part of the spine and you get rid of some of the buckling. If you're going to use a hyperlordotic cage at the front, then yes, you need to do enough of a decompression of the back to make sure that you don't get buckling of the flavum and a neurological problem. And then I did a Ponte osteotomy L5S1 through the unfused spine segment. And so you can see then really, again, same as the last patient, a 40-degree correction without a subtraction osteotomy, 680 mils of blood loss, tiny, didn't pass the neurological structures and didn't give the patient a risk of neurological injury, like the SCOLI risk one paper had shown previously. So this is quite easy for everybody, really. It's a laminectomy at the back. Not a huge laminectomy either. It's anterior column reconstruction at the front, and then it's just closing down the rods at the back, giving you a great correction and really taking away the neurological risks and also decreasing the amount of blood loss that you have with these patients. They do phenomenally well after surgery. So if you avoid the PSO, you can see actually that this patient is completely different. Even though you look at the x-rays, I think x-rays don't really tell the whole story. You look at the x-rays and you think she's still a little bit kyphotic in the upper thoracic spine, but actually when you look at her, you have freed up the hips completely by doing an anterior column reconstruction. You don't get the same look as that with a PSO. Patients don't actually function, in my opinion, what I've seen over the years, they don't function as well as this after they've had a PSO done. And they don't look as if their hips have been freed up so much. Again, her quality of life outcome scores are phenomenally better than what you would see in the normal population. They're just so grateful, these patients, to have been corrected. So we went on then from describing the actual operative approach to detailing a number of patients who had effectively the most complex reconstructions by us by going through the anterior windows. And what we did was we published that then, Moby and myself, and Darren Louis was my fellow at the time, and Joe Butler had been a previous fellow of mine. So there are two names that you will all know as well. They both came through our stable, and Obi and I were able to pass on knowledge to them, really. And so what we did was we actually decided we would look at the patients, the worst patients from the SCOLI Risk 1 paper, and we would take effectively the Lenke Silva type 6s, so the very, very stiff or fused spines, and we would do an anterior column reconstruction on those patients. So this was taking down fusion masses, freeing up areas that were completely stiff. I think if you're going to go back and look at the classification of what's stiff, what's not stiff, what's flexible, go and look at the Bridwell classification. There's a fantastic supplement on adult deformity corrections, probably 18 to 20 years ago. Beautiful paper written by Keith Bridwell, a great understanding of the spine and a great teacher in his time. So what were our aims, really? I wanted to look at my own PSOs versus my own anterior column reconstructions in those Lenke Silva type 6 patients, the really, really stiff and fused patients. I wanted to look for new neurological deficits to see if I actually was doing better than I was in my PSO days. It was me, just a single surgeon, so at least it was me against myself. So yes, it's a very, very small study because it's one surgeon and it's not reproducible across many units, but at least it actually shows you that actually it's matched, really. So we took all of the data that the SCOLI Risk 1 paper had taken, but we actually did a couple of extra things. We took out the patients who were under the age of 45 because they do a bit too well sometimes. And we also excluded patients who had AIS and then degenerative progression, and the patients who had skeletal kyphosis deformity, because actually really they're just pediatric patients who actually get degenerative progression later on. They're easier actually to fix. So not just de novo degenerative scoliosis. We looked at 268 patients between the 2007-2015 time where I operated on that amount of patients. And what we saw was that we were able to put 34 patients into both groups because we were taking, remember, just the very, very fixed and fused spines, so the very stiff ones. So the Lenki-Silva type 6s. And you can see the blood loss was a lot less in the MOLIF group. The operative time was also a lot less. And the number of fused levels was just a little bit less. It was 9.5 versus 11.5. But these are big surgeries. They're big reconstructions. And all of these patients are having a multi-level anterior reconstruction to include L5S1. So they were matched then with the PSO group. And in the new neurological deficits, you can see that in the MOLIF group, we had 2.9, which was a temporary neurological deficit, and 0 going forward after 6 weeks. And I can tell you that actually to this day, we have done unbelievably well with a neurological deficit. New neurological deficit is nowhere, it's not even remotely close to the PSO data that's in the literature, and also what I had myself, which was 14.7%. And I would implore everybody to look at anterior column reconstructions. And I can see that through the LinkedIn posts that I see, on a day-to-day basis, everybody's getting interested in this area. And it's great to be able to present this, of where we actually got interested in this kind of 17 to 20 years ago, really, and the journey that we've actually done. So this was the data that we had actually pulled out. And you can see that actually it produces exactly the same global lordotic reconstruction as a PSO from L1 to S1, but actually it gives a much better restoration of L4 to S1 reconstruction, because even if you do an L4 PSO, you don't get the same lordotic reestablishment from L4 to S1 as you would get when you do an anterior column reconstruction. You don't free up those hips as much. So when you look at these patients, you can see on the right-hand side, this is a very, very old picture, nearly one of my first that actually happened with the tantalum cages. You can see one of those tantalum cages in the middle is really, really big, because we only had certain sizes of cages and then you just put in what you had. But you can see it's a very harmonious spine. And actually, that that's not going to produce a proximal junctional kyphosis, or at least it's not going to produce a proximal junctional failure. I don't see proximal junctional failure at all. Of course, proximal junctional kyphosis or degenerative change happens a little bit, but really I'm not adding on like I'm seeing in the literature, because I think we're developing a better segmental correction. So if we go back to the Russley classification, I think this is the interesting bit from the talk that everybody needs to go and read about a little bit. So Russley was a seminal person at actually showing us what types of lordosis we should be trying to achieve. And then, of course, understanding the difference between the upper and the lower lumbar spine. So we did a huge amount about this, and I'm very grateful to Hani Anwar, who's a consultant colleague of mine now at Stanmore and a very, very brilliant surgeon. Hani was our fellow at the time, and he kindly wrote this paper up with me. Joe Butler was just finishing off as fellow, and Hani had come. And I said to Hani, I said, look, we need to look at the pediatric population and we need to try to see what is their segmental lordosis. These patients were coming with a 10-degree scoliosis, and somebody had done an AP and lateral whole spine erect X-ray on them, including their proximal femora. And we were able to therefore have a look at L4, L5, L5S1 and see what the degree of angulation was. What we found was really, really quite striking was that actually it was quite reproducible, that actually the lordosis, irrespective of the pelvic incidence, between L4 and S1 was about 35 degrees. So that was something completely different, and it was different from what Pierre Russley had written. Of course, he had talked about the difference between the upper and the lower lumbar arcs and curves in the lumbar spine, but actually this was very, very different. And what we found was that the upper lumbar spine fine-tuned for the higher pelvic incidence patients. So we basically coined the phrase the L4MS, which was the motor segment, the L5 motor segment. So the L4 motor segment was the L4 vertebral body and the L4 L5 disc, and the L5 motor segment was the L5 vertebral body with the L5S1 disc. And we saw the results as you've seen there, but also we recognized the fact that there was lordosis within the vertebral bodies, and we didn't feel anybody had taken that into account. And I still see people templating things and saying, I think I need a 15-degree cage at 5'1", when actually the L5 vertebral body is often 16 or 17 degrees lordotic already. So sometimes I think we overcall it at the moment. Joseph Baker, who came through with us at Stanmore as well, spent a bit of time with us, not a full fellowship, but great guy and a great researcher down in New Zealand, looked at some CT images and had a look and realized also, and showed us here, and you can see for different PIs that actually the L4 and the L5 vertebral bodies are have a different lordosis. So you can see there that actually in a high PI, the L5 vertebral body often has a lordosis of between 12 to 16 degrees. And we see that a lot, particularly with the isthmic spondies as well. So have a look at them. I saw one the other day, had a 27-degree lordosis at L5, but of course that would have been a little bit of wear and tear as well. And then our paper, it takes 10 years for any good paper to get pulled up by anybody. And thankfully, Virginia Lafage, Frank Schwab, and Larry Lenke, who are great researchers and fantastic people, picked it up and actually wrote a paper that reference was #1. And they said that basically their series found exactly the same as we had. So that was striking, wasn't it? So if we look at what they found and what we found was in the red box at the top there, and you can see that our L4-MS, our motor segment, was actually 16 degrees, and our L5-MS was 20 degrees or 20.5 degrees. And then just below, you see the big red arrow there going down to the segmental lordosis that they found, which was pretty much exactly the same. So now we had two big groups, but theirs was a much bigger cohort of patients, of course, because they've got a big data set saying the same thing, which is that the lower lumbar spine needs to be respected. Now, how important is that for low back fusion surgery? Because the biggest amount of deformity I still see these days is iatrogenic deformity. People who do low back surgery and unfortunately leave patients a little bit flat. I have seen people overlordose recently because people are doing some anterior column reconstructions and putting two hyperlordotic a cage in at L5S1 and L4L5, but that's for a different day. Then Diabo and Alan Daniels and Virginia Fage wrote something that I think then has given us the fine tuning of what we initially wrote and what Virginia then wrote after that. And this was a very, very good current concepts paper. They didn't review our paper in it at the time, but if you look at the fine tuning, it says the same thing as our paper did. Between a pelvic incidence of 50 and 70, you're still looking for 15 degrees when you're counting the vertebral body of L4 and the disc space of L4, L5, and you're wanting 20 degrees if actually you're counting the L5 vertebral body and the L5S1 disc. Now, importantly, just there are some outliers. Of course, if you get to a much higher PI, then of course you need more lordosis at L4, L5, and L5S1, which is not something that our study had found or the initial study by Virginia Lafage. But I think this is the work that should come with you. Now, if we look at this and have it in modern day terms in comparison to the L3 PSOs we did in the past, well, we were supposed to get 84% of our correction or lordosis in the actual disc space itself, but we were doing PSOs through the actual vertebral bodies themselves. And also for a PI of 60 degrees, you were supposed to have a lordosis of 11 degrees at L3, L4, and actually what were we getting? We were getting 33 degrees often, and even a bit more because the actual disc below would have been a bit lordotic as well. So we were getting the lordosis in the wrong place, and it wasn't surprising that we got a lot of proximal junctional kyphosis. So what do? I template an awful lot of these patients beforehand. I particularly look at their CT scan beforehand, or the SPECT CT scan, or the MRI scan, and then intraoperatively as well, I will actually ask the rep kindly to do the lordotic angle after I've put a trial in at L4, L5, or L5S1, and I will see whether in fact I'm close to what I'm trying to achieve based on the pelvic incidence that patient had beforehand. So other things to remember: if you're going to put a biconvex trial and therefore implant into, let's say, L4, L5, and L5S1, if you put it on the dome of the sacrum and actually they're really quite convex already, then you're going to get a lordosis that it's not what it says in the box. A 15-degree lordotic cage is not going to give you 15 degrees. So make sure you put the trials in, make sure you have somebody who actually measures that for you, and I think that's going to change your outcomes and change what the patients look like segmentally afterwards. Just very quickly, because I know we're coming towards the end of me talking really, but this is a patient I presented in Stockholm at the SRS, the last SRS, which produced some very, very interesting conversation. We were asked to bring a very, very difficult case. I was there with Paul Sponseller and various things, and Laurel Blakemore, and we were asked to give some tough patients. And I put this one up, and I could see the audience thinking, well, it's not that tough. It's just an adult deformity case. And I asked everybody, how do you want to fix it? You can see that the L4 to S1 lordosis is actually really quite good. It's nearly 50 degrees. And the actual pill mismatch not that bad at all, but actually the pill mismatch is off because of the upper lumbar spine. So there's a thoracolumbar kyphosis of 33 degrees. And if you actually look at the patient lying down, so on their scout CT scan view, the thoracolumbar kyphosis is stiff, it doesn't change. So it's still 33 degrees. And you can see the CT scan there that actually a lot of those disc spaces are trying to go on to fuse. So what would you do? And I pushed everybody about it, and I was a bit harsh on a couple of my friends and said, right, so what would you do? And in the end, they said, I'd do a PSO. And I said, well, where would you do a PSO? And they said, lower lumbar spine. I said, well, it's already got a lordosis of 50 degrees. Do you really want to do that? And then they pushed it and said, okay, fine. I'll go to the thoracolumbar junction and I'll do a PSO. So now you're starting to do a PSO at the level of the conus. That's a difficult operation. It's a higher neurological risk. And so actually then I showed them what I did, which was actually just to effectively do a 3-stage procedure, releasing the back, putting screws in. So you release the back so that actually you can put the cages into the front, take down some of the kind of areas that are trying to auto-fuse, and then you make a spine very harmonious. What came up in that meeting as well was that Manish Gupta said to me, oh, you can't stop at L5. I said, you can stop at L5. If you get a harmonious spine, you can stop at L5 as long as the DEXA scan is all right, or actually I think better these days to do a CT scan and do some Hansfield's unit and find out what that's like. So you can stop at L5, and it goes against the grain and goes against what's said in the literature, but you can if actually you make the spine look like a spine again. So these are just a few images just to show you the top line or the before, the bottom line or after. And the only takeaway in this slide is make a spine look like a spine, and then it'll last for you and you won't get proximal junctional kyphosis. So here, just very quickly, you can see this is a patient who has had fusion before, multiple fusion operations and multiple excursions into her spinal canal. You'll see her walk now, but you can see that she's got a fixed abnormal deformity from L4 to S1. And actually, in addition to that, she has a coronal imbalance as well. And you can see her walking down the corridor here. She's actually using her right arm to try to hold herself upright. And then when she takes that away, she gets even worse. And then if we just look at her afterwards, I decided not to do a PSO on her, but to stick with my tenet of doing an anterior column reconstruction. And I did a posterior release in her first off, and then I did an anterior column reconstruction. The main reason for doing the posterior release and putting the screws in, however, was to take away any of the flavin, because I was going to put a hyperlordotic cage in. So just be very careful of that, otherwise you will run into some problems. And Baruzek Barnia and I discussed that about 17 years ago at Stanmore. So interesting how these things happen, and they have crept into the literature, of course. So even when you can't reestablish the segmental lordosis from L4 to S1 in this case, you can actually try to do the best you can possibly do. And then I'm sure you'll all agree that actually she is a completely different patient after she's actually had her reconstruction. And she's only 49 years old. So that's a big correction for a patient like this. So I'd like you to go and look at a couple of the papers. One, the approach paper, just so that you can all be versed on how you might actually get to do an ALIF at 5.1. I think everybody's understood or at least read about how to do anterior psoas. And then have a look at our paper that compared the Lenki-Silva type 6s and look at the PSOs versus the anterior column reconstructions and how you might be able to do that. There's a few other examples in that paper of stiff and fused spines and how we actually took them down and reconstructed them. So this is also what you need to go away with, really, is an understanding of what you're trying to recreate from L4 to S1. And I think actually Basil Diabo has given you a beautiful table that you should bring into your OR, and I think that should be up on the wall, and I think every rep should have it, and the reps should be able to have an app on their phone that actually is able to measure the angulations for you from the top of L4 to the bottom of the cage at L4, L5, and then again at 5.1, so that you know that you're reconstructing even in the low back patient. Occasionally, however, you do need to do a PSO, and I still do PSOs, but in a very, very small cohort of patients. But this was an L4 corner osteotomy that I did in this patient, and it's important to kind of be able to do a PSO as well. She had a massive coronal and sagittal imbalance, and of course, for these cases, you do sometimes need to do that. You can see I did a supplementary L5S1 anterior column reconstruction as well, so it's a mix and match of two techniques. So in conclusion, understand what you're trying to achieve segmentally. Check intraoperatively that you're actually doing that. try not to pass the neurological structures unless you have to. So if there's a weak link within any previous construct or within actually a virgin spine, try to go anterior and posterior to the spine. And I think actually with that in your armamentarium, you're going to have to try to actually work with an access surgeon. I think that's safer for you in the longer term. I did all my own approaches. Initially, I'm much better off with an access surgeon. And I think, by the time you get to the spine, you've then actually done an operation you weren't necessarily trained to do. And I did a lot of vascular surgery in my training. In the UK, we do an awful lot of everything else. But I would still say to you, don't do that. Just like I say these days to people, you should try to use navigation and computer technology to help you, because I did freehand screws for a long period of time, but embrace the technology, embrace the change. Thank you very much. Raj, I really appreciate your offer and invite to come and speak.
Thank you, Professor Molloy. It was just beautiful, incredible talk. Like the kind of talk you gave the audience and the message I'm receiving, like just fantastic talk. You simplified the technique. You informed how to do it, what to achieve. Keep 15 degree at 4.5 and at 5s 120 at the levels when the PI is around 50, 60, and 70. And it's been published for over the 2 decades. That's such a fantastic thing, and everyone now is talking about it. Yes, what you kind of published 2 decades ago is kind of validating all your research. So we are very fortunate to have you, and thank you for your teachings and learnings. So just to ask you questions, maybe just 2 questions. Do you have any video with you? Is it possible to play or?
So I don't have a video. I mean, I would probably have to go through my computer
That's
now,
fine.
which I can try to do to find for you. I can probably find it. I gave a I gave a video presentation at IMAST, would you believe,
Hmm.
probably about 12 years ago on the
Oh.
anterolateral approach and getting to 5-1. But if anybody wants to look at the video itself, I think the
Hmm.
best way to look at it is to go onto the Remesis website and go onto the World Surgery Summit Tour, where Obi and I
Great.
actually did the approach, and we described it very, very well, and we showed in the cadaveric dissection exactly how to do it. And it's an hour long, and I think you'll glean an awful lot of technical tips from that as to how to get started.
Great. Thank you, Professor. Again, just to understand the workflow, it works. So you kind of start posterior, put the screws, maybe do some osteotomies, uh, and after that, in how many days you take for the anterior surgery, or how it works in your workflow?
Raj, that's a great question. So it really depends on how stiff the spine is. If the spine is incredibly stiff and or the patient is really quite osteoporotic, then actually you need to start posteriorly, because you need to release the spine and release the facet joints posteriorly. Whilst I'm there, I put all the pedicle screws in so that actually that's a large part of the operation done. Usually the next day or 2 days, hence, before they kind of get all of the problems from the first stage operation. I don't leave them a week in between. I try to stage them so that I actually do it the next day or the day after. Then I'll go into the anterior space and I will actually then free up the spine and put cages in and reconstruct them. Or if they're not so stiff and they are reconstructible first off, and I don't need to release the posterior elements, then I will always start with the anterior column. So I won't actually put a rod in through the back ever, first off. There is one caveat to that, and I'll tell you that in a second. And that is because you don't want to fix the posterior column of the spine. But early doors, that's what Pierre recently was doing, so I did it as well. But now I definitely want to do my first corrective technique is always done anteriorly, but it might be the second stage of the operation. And the third stage, if there is a third stage needed, is done on the same day, where actually I just flip the patient and then put the rods in. If actually they just need two-stage surgery because they're not so stiff, then I will do an anterior column reconstruction over multiple levels, and depends what their PI is, to many levels they get, and the amount of lateral listhesis, spondylolisthesis at various levels, for instance. And then actually the next day or the day after, I'll do a posterior and put all the screws in, do whatever bony work is needed, and then the rods. So it's not one size fits all, really. It's actually trying to have a cookbook for the patients in general. There is one caveat, and I've done it a number of times. If a patient has, if somebody's been in their spine huge amounts of time before, they've had 3 or 4 decompressions, they've had a previous infection, potentially they've had dural tears, then what I will often do is I will go into the back, put rods in, and I will do like a modified Schiller technique where I will overbend the rod and I will put the nuts on the screws, on the screw heads, and I will allow sliding of that rod. I will then go to the anterior column and take a fusion down in the anterior column. So go through the disc space that's actually fused. I'll break it, and I will actually then lever that up with a few little old tricks and tips and tricks, and I can share that with people on a different date. And then I will actually get the spine to correct. I'll put them supine, I'll put them over a very large black pillow that we have, big like a memory foam pillow. And as they slide, the Schiller technique at the back will allow guidance of actually that, so you don't get translation. Because of course, if you undo the back, take down the back completely, and then you undo the front, then of course you've got instability of the spine. So you need to be able to, with the black pillow, you actually have a harmonious lordosis of the spine, and then the Schiller technique at the back, then you can push the disc space up that you've opened up in the fusion mass, and then you can put a cage in there. And if you get the required lordosis, and you can check it on the table just by getting the rep to measure everything, then you can put a plate on the front, of course, and then go around the back.
That's very well explained. Thank you so much, Professor Molloy. We really appreciate your time. I think that's it for the today, and we are very thankful for your time.
Raj, an absolute pleasure. Thank you very much for the invite.
Thank you.
Take care.
Poonam ma'am, I think we